Olá, sejam bem-vindos. Aqui é Bruno Benigno, direto do 38º Congresso da Sociedade Europeia de Urologia. E aqui eu tenho o prazer de entrevistar a doutora Renu, que apresentou os dados do LuTectomy Trial. Dr. Renu, it's a pleasure to have you here.
Thank you so much.
Could you please introduce yourself and talk to our colleagues in Brazil about your results? It could be the end of surgery?
Oh, look, well, firstly, to introduce myself, Renu Eapen. I'm a urologist at Peter Mac in Melbourne, Australia, with a particular interest in PSMA imaging and theranostics. And so, yes, I presented the results of our LuTectomy trial, which is a phase 1 study looking at the dosimetry, safety and feasibility of lutetium treatment prior to radical prostatectomy in high-risk localized prostate cancer. So this really is one of the earliest uses of PSMA theranostics to treat in a sort of an upfront neoadjuvant setting. So really the main aims of this trial, we wanted to see if it was effective in delivering a good dose of radiation to tumour tissue, and then secondarily see that it is safe, tolerated well, and importantly to make sure that surgery after this treatment is safe for patients. And that's what we did. You know, we found that we could deliver quite significant doses of radiation to tumour tissues, including the prostate and the lymph nodes. You know, the important thing about radioligand therapy that distinguishes it from external beam radiation and brachytherapy is that it's a very targeted form of radiation. So it really is delivered to the cells that express PSMA. Just like imaging identifies those cells, but we've tagged a radioligand agent onto that, and so the scatter effect is very low. So it doesn't treat tissues surrounding it. It is very, very focused within the area of the prostate and lymph nodes that have disease. So this actually translated into our surgical findings because we found that surgery was very safe. You know, there was no evidence of fibrosis or significant increase in surgical difficulty. The treatment was tolerated very well, very low grade adverse events, which were self-limiting, and no surgical complications that were attributed to lutetium PSMA. So, you know, these were the primary aims of the study. The oncological outcomes, you know, they were secondary. We did look at imaging response, pathological response, and PSA response. But you know, as you know, long-term oncological outcomes take a long time in prostate cancer to come across.
Yeah, for sure. And one of the aspects of your data is that we don't see any pathological complete response to that. And do you know what? And I saw in your presentation that maybe it's because in the early stages of prostate cancer development, maybe the cell doesn't express that much levels of PSMA. That makes sense. Or, you know, my question is, maybe we will see more effect, oncological effect and treatment effects of lutetium in the more advanced stages of prostate cancer because of an theoretical increase in expression of the biomarker, or not? They think this doesn't matter the scenario.
Well, I mean, this is a treatment that specifically targets PSMA. So we were quite selective with our patients. You know, all these patients had high PSMA expressing tumors, so they had to have an SUV max of at least 20 to be eligible for the trial. So that was one main point. You know, we were not pathological response wasn't the intended outcome of the study. You know, we looked at it because we had access to tissue pre and post treatment. You know, one of the reasons why we didn't see better pathological response is we operated too early. You know, the effects of radiation can take many months, and so we did our operations about 6 weeks after the last treatment of lutetium PSMA. Remember that this is an initial proof of concept trial, so these are high-risk prostate cancer patients. Until we knew it was safe, we did not want to wait longer to operate on these patients. So, you know, when we design the next randomized phase 2, phase 3 trial, these are the sort of questions that we have to answer. You know, do we need to give more lutetium? Do we need to give, you know, a higher dose or more cycles? Do we need to wait longer before surgery? Do we need to give lutetium in combination with some form of radiosensitizing agent to help it work better?
Yeah, interesting. My last question is about when do you look at the pathological response and the clinical outcome and the oncological outcomes, and comparing other drugs like, you know, abiraterone and apalutamide in this space, it seems that we have more pathological effects than we see on the LuTectomy trial, do you think maybe is the reason for that is the time? Maybe the ADT blockage is more quicker and more
Sure,
rapid,
I mean that could be one, but also remember these are completely different treatments. This is an upfront neoadjuvant setting. These are otherwise well patients, so we also don't want to expose them to the toxicity of medications like that. And that's the beauty of lutetium PSMA given in a neoadjuvant setting, is that it's tolerated very well. The risk of adverse events is very low, and if complemented by something like SBRT or even surgery, that then could be a sound strategy in very selected patients in the future to possibly decrease the rate of PSA relapse, biochemical recurrence, and metastatic disease. But that needs more study.
So thank you. It's a very, very honor having you here.
Thank you.
And I wish you well and good data. I know that good data will come for you soon.
Thank you so much. I appreciate it. Thank you.
Appreciate. Obrigado, pessoal. Até a próxima no nosso SBU in situ. Obrigado pela atenção.